Erasmus University Medical Center in Rotterdam in the Netherlands. He leads the Pharmacogenetics core laboratory. He has a focus on pharmacogenetics, both research and clinical implementation. He participates in international advisory committees on pharmacogenetics, and he is in the steering committee of the European Pharmacogenetics Research Network. He has been awarded the Poster Award for Outstanding Scientific Research in 2010, and since 2008, his laboratory is internationally recognized as an IFCC reference lab for pharmacogenetics. Please, Dr. van Schaik.
Okay. Thank you very much for the kind introduction. You did a very thorough study of my CV, I saw. It's my pleasure to be here. I think this has been, so far, at least as I can see, a great meeting. We just heard a very impressive talk before this about all kind of research. Unfortunately, I'm going to take you back down to earth to the simple question, all this pharmacogenetics, can we really apply that into the clinic? And we have been trying to do this for the last 7 years, and we'll be happy to share with you some of the frustrations, perhaps, or some of the new insights which we had trying to get pharmacogenetics into the clinic. As I said, I work at the Department of Clinical Chemistry, and working there, you see all this literature oncoming on pharmacogenetics. We see a great increase in the number of publications, either on pharmacogenetics, pharmacogenomics, or personalized medicine. And we just heard that Mayo Clinic will add several other ones. And of course, all these articles need to be read by somebody, which is unfortunately me in our hospital. You have to pick out the right papers, the right markers, set up an assay in the laboratory, go to the clinician and convince him that he can use this to make this patient better. So that's more or less the procedure, the translational research, what I'm working on. And of course, the end goal is that you can provide a DNA profile or an analysis of metabolizing enzymes, for instance, for which the patient can go to the local pharmacy and ask medication for that particular patient, like personalized medicine. Okay, so there are several hurdles to take. And I'm not going to dwell very long on this one because these are the very obvious ones. Like, it needs to be like a proof of principle. So if you have a pharmacogenetic marker affecting a metabolizing enzyme, you want to see that this marker has an effect on pharmacokinetics. Proof of efficacy, the patient should benefit, so there should be an effect on pharmacodynamics. A test should be available, was already mentioned earlier. And if a test is available and you would actually need another treatment, there should also be alternative treatment available, either another dose or another drug. Cost effectiveness has been mentioned as well as one of the hurdles to take for pharmacogenetics to get implemented. And then last, but certainly not least, uptake in guidelines and convincing clinicians, which is more or less a catch-22, I learned, because to get it in the guidelines, you have to convince the clinicians, and the clinicians are not convinced because it's not in the guidelines. So, okay. So how does it work? Well, I have this very classical example of the TPMT genes in 6-mercaptopurine or azathioprine therapy. I think it's one of the classic examples of pharmacogenetics. 3 SNPs in the TPMT gene, and you get a very good correlation with TPMT enzyme activity, like 95% concordance. Genotyping can predict for 95% the phenotype, the enzyme activity. And I think this is a very good marker to be used. But if you look at the timeline here, like I think it was already in 1980 that it was kind of seen that the TPMT activity was kind of an inherited trait. It was in 1995 that the SNPs were discovered. And we're now in 2012, and when you look in your own laboratories, is this already implemented or not? Well, not that much. And in fact, there was a paper in 2007, that's why it's highlighted here, and there was a UK questionnaire among prescribers of azathioprine. And TPMT enzyme testing, which is more or less in the label, was done by 70% of the physicians, whereas the DNA testing was only done in 5%. We're talking about 2007 here. I mean, doing a genotyping is not that complicated. So apparently, it did not find its way into the clinic. And what I was a little bit surprised of that, in that specific article, it was referred to that DNA testing for TPMT was not routinely available. Well, I know there were several labs that were doing that, but not many. So apparently awareness that the test can be done was quite low. What is our own experience with this TPMT genotyping? The dermatology department does a very good job. they always ask TPMT genotyping before they prescribe azathioprine. And when I asked them, they said, well, it's in our guidelines, and that's how we do this, and it works perfectly. So they're very happy with it. Gastrointestinal department, I'm not sure if they do it always, but I get several requests to do TPMT genotyping before start of the therapy. In case of acute lymphatic leukemia, so for 6MP, it's a little bit difficult because apparently there was a competition with the national protocol, and the national guidelines said you have to do TPMT enzymatic activity, and based on that you prescribe the drug. So we had a competition between the genotyping and the enzyme activity measurement, and I think it's more or less logical that apparently then the guideline is followed. However, there was kind of a turning point, and that was with the awareness that the genotype results were available in 3 days, whereas the TPT enzyme activity took like 2 weeks, 1 to 2 weeks. And it cost us only like 80 euros in our laboratory. And then all of a sudden it became more interesting to the physicians to ask for the genotyping. It's still not done routinely for them, but we get more requests. So these are our experiences with the TPMT. And I think for pharmacogenetic reasons in our hospital, this is more or less a success, although it's going very, very slow. So we have this very nice form which can be filled in if you want to have a specific gene tested. It asks for which drug are you looking at, what is the dose you prescribed it, what is the concentration that you measured, is there co-medication, and then of course what is the problem? Is it screening prior to therapy? Is it because of high or low blood levels? Or is it on the pharmacodynamic level, so no effect or side effects, and please specify. And then the several genes can be crossed if you want them tested, and of course, completely to the side, is unknown to me, please advise, and we'll be happy to provide you with an advice on which genes needs to be tested. If you're more clever than us, you can also fill in other gene, please set up this assay, and we'll do that for you as well. Well, one of the biggest hurdles in implementing pharmacogenetics is right here on this slide. It's not filled in. Usually we get something like, please test CYP450. No drug, no reason for testing, whatever. Most of our time we spent trying to get to the clinician who ordered the test to find out which drug was actually prescribed and what the actual problem was. And it goes, this physician has a patient, like imipramine patient, has severe side effects. He heard Dr. von Schaik speak here at EMEA, and he thinks, well, I'm going to ask the test. So he asks the nurse writes in a form, goes to their own laboratory, they do not do the test, so they send it to a central laboratory, they do not do the test either, they write down again another form, and then they send it to me. Sometimes they ask for 2D6 where 2C19 is mentioned, sometimes just like CYP450, so there's a big complication there. For me, I think this is the biggest hurdle for implementation of pharmacogenetics, but I'm sure we get further with this. So how are we doing with our pharmacogenetic testing? Going from 2005, when we started, to 2012, I think there are moderate figures, but what you can see here that there is a gradual increase in the request for pharmacogenetic testing. And we're now up to something like 500 patient requests per year. So there's an increase, and I think there's more and more awareness, and approximately like 2/3 is getting out of the hospital, and 1/3 of the requests we are receiving from inside the hospital. So I think there is an uptake of pharmacogenetic testing. And I'm going to show you 3 examples on the fields in which I think that pharmacogenetics could make a big difference, and our experiences when we try to implement this. And the first one is on the antidepressants. So this is in the psychiatry. So in our academic hospital, we prescribe imipramine as an antidepressive, and it's converted to desipramine. Both are active, but the inactivating step is by cytochrome 2D6, for which 5 to 10% of the population is a poor metabolizer, and 2% is an ultra-rapid metabolizer. The dosing is adjusted in such a way that the patient will get the plasma concentration within the therapeutic window. Usually takes 4 to 6 weeks in an academic hospital, because you have to wait for 1 week before their steady state. Then the dose needs to be adjusted in approximately half of the patient. You have to wait for another week, 4 to 6 weeks in an academic hospital. So the reason, if you looked in at the 2D6 genotype, is there a correlation between the number of 2D6 alleles, which is on the x-axis, so 0, 1, 2, or gene duplication, compared with the imipramine dose in which the patient reached the steady state? And as you can see here, this is the averages of the group. It's like a total of 180 patients. There is a very nice correlation. And in fact, you can see that the poor metabolizers with 0 2D6 active alleles need approximately 30% of the standard dose, which is more or less, which also came out of one of the nice papers of Julia Stingel. So we thought we had a good pharmacogenetic approach here, and I tried to talk to the psychiatrist if you could use this or not. But what happens if you plot in the individual patients here? Because this is a very nice scientific paper, but the individual patients in there, then all of a sudden the picture looks like this. You can understand, well, if you're very optimistic, you say, I can still see a correlation here. And if you're more pessimistic, you say there's so much overlap that the value for the individual patient is not very high. And this is actually what's also happening in our clinic. It's not requested beforehand, but it is requested retrospectively if there are problems with the patient. If the patient is on imipramine and he has side effects, usually they put him on another drug, again side effects, then they ask for the genetics to see if that's the reason why there are side effects, if he's a poor metabolizer or not. Or, and that's even more often, a patient gets prescribed a drug, there's no effect, there's no blood level. Is the patient taking the drug or not? And before engaging in that kind of conversation, it's more easy to see if you have an ultra-rapid metabolizer, which could explain why this patient is not doing well. So most of our test requests are like for non-compliance. So the second example, cytogram 2D6 and tamoxifen, which was referred to just a talk before and also yesterday. Tamoxifen metabolism, it's metabolized in 2 steps to the active component, endoxifen, and this is also metabolized by the cytogram 2D6. So going to the oncologist saying, well, should we do 2D6 testing here? First of all, endoxifen levels, are they influenced by the cytogram 2D6 polymorphism? And the answer is yes. This is one of the first studies on endoxifen in 2005, showing that if you're wild type for the 2D6, you have higher average levels of endoxifen compared to patients who are homozygous variant, completely to the other side, approximately a factor of 4. So we have some proof here that the genotype gets an effect on the pharmacokinetics. But of course, it's the pharmacodynamics which is more important. And I chose one of the biggest studies, and I think one of the well-conducted studies on 2D6 and tamoxifen, and indeed showing that if you're a poor metabolizer, there's a lower survival proportion compared to intermediate and extensive metabolizers. And I think this is a very good test and very good utility of pharmacogenetics because you have to predict efficacy. As you heard yesterday and today, there is a little problem here because there are contradictory results. Approximately 10 papers have described a positive association between 2D6, poor metabolizers, and lower survival rates, and approximately 8 papers have shown that there was no effect. How do you solve this? And especially 2 papers which were presented at the San Antonio Breast Cancer Conference in 2010 really made a change in our clinic because all the oncologists went to the San Antonio Breast Cancer Conference. There were only abstracts, there were no articles, no real evidence, I would say, but they got the message that 2D6 testing was not important, not good enough to guide tamoxifen therapy. And it lasted for, I think, 1.5 years before actually the papers came out, and we were able to evaluate what was actually being done. One of the papers analyzed only the star 4, it's in 1,200 individuals. There are some papers that said that you need at least to do more variant alleles of the 2D6. And the other study, which was, I think in something like 4,000 individuals, only 580 got tamoxifen. And there are some arguments there that a recent publication in GCO and a letter from Mark Retain saying that this study was not in Hardy-Weinberg equilibrium, by far not in Hardy-Weinberg equilibrium, and perhaps should be withdrawn from the literature. So what's the evidence? How do we proceed with this? I think the main problem here is that if you're like a clinical pharmacologist or a clinical chemist, you go to HCPT and we all talk together and we're very enthusiastic about the possibilities of 2D6. Whereas all the oncologists go to other meetings and they talk to each other there. So in fact, the problem is we're not talking to each other. And the way I see it, we have this controversy. We have like a laboratory or clinical pharmacology view saying, okay, 2D6 is theoretically involved. Genotype proved to affect metabolism and proved to affect outcome. Whereas the oncologist view, and I think that's also a very proper view, like not all studies confirm the effect of 2D6 on outcome, and there has been no randomized controlled trial available. It's a stalemate. Where do we go from here? One group says we can use it for clinical implementation, the other group says we cannot do it. Meanwhile, we have the patient, which is kind of in the middle of this. I get a lot of phone calls from patients saying, I visited my oncologist, I had breast cancer, I'm getting tamoxifen prescribed, and I looked on the internet and I see that there's this 2D6 genotyping. If you're a poor metabolizer, tamoxifen may not work as well for me. I want to be tested. I talk to my oncologist and he does not want to test me. Can you test me? So you have to explain, well, the oncologist, even if we test you, has some difficulties, because if he's going to treat you differently, he's going to deviate from the guidelines. And the guidelines have not been changed because the oncologists have not been convinced. So I don't think we have completely solved this yet. And of course, you all know that if you use antidepressants, you're also reducing 2D6 activity. Well, that has been taken up quite quickly without any argument. So I think the interesting part for the oncologist, and I asked them that question, is what do you do if a patient gets to your clinic who already has her 2D6 genotyping? You know she's a poor metabolizer. Are you going to ignore that result? Are you going to ignore that information? Or are you going to follow the guidelines? I think this will be the very interesting topic to see in the next years where this is going. Okay, so the third example, 2C19 and clopidogrel. Also mentioned earlier. Clopidogrel needs activation by cytochrome 2C19 to be active. 3% poor metabolizers, 26% intermediate metabolizers, approximately in the Caucasian population. So there has been a very nice meta-analysis. There have been several meta-analyses. This is one from 2011, which kind of shows that if you're a carrier of the cytochrome 2C19 STAR2 allele, then you're at risk, either one or two. You should not get clopidogrel, but you should get prasugrel. I did speak to our cardiologist, and they said, well, you know, if the alternative is prasugrel, we put everybody on prasugrel, which is, of course, also a way out, because then you do not have to think about the laboratory test. And one other issue is that the laboratory test goes from the department budget, whereas the drugs go from the hospital budget. I'm not sure how much that played, but you know, it's a consideration. But now the interesting thing is that there is another meta-analysis in 2012, and they showed that if you have small studies, they kind of confirm the risk of having this variant allele, but the larger studies do not show this effect. Now, it depends very much if you're a cardiologist and which time frame you kind of looked at the literature, so to say. Because I know in the Netherlands, in the Antonius Hospital in Nieuwegein, they do 2C19 genotyping, and based on that, either prescribe clopidogrel or prasugrel. And in my own hospital at Erasmus, they say, no, we've seen this other meta-analysis, and we are not convinced of the results, so we're not doing that. So within the same professional organization, different methods are currently being used. After these three examples and showing one of the problems to get it implemented, one word on cost effectiveness, one of the hurdles perhaps to take. I do not know too much about cost effectiveness. There is this one study on 2C9 VCORC1 testing for warfarin, and there's a lot of in the abstracts which I do not very well understand, so I usually just read the conclusion, and the conclusion says genotyping is unlikely to be cost effective. You say, damn, okay, well, it's not going to work. But then I read further through the abstract, and there's one thing I do understand. It said the cost of testing is assumed to be $400, 300 euros. Well, if something is not set, it's the price of the genotyping. It differs. For instance, in Erasmus, we do the genotyping for VCORC1 and 2C9 for 160 euros. And if you read then the abstract more carefully, it said that it can be cost effective if available within 24 hours and cost less than $200 or 160 euros. So I think this kind of study should not say it's cost effective or it's not cost effective. They should just specify what the cost of a test may be in order for pharmacogenetics to be introduced. To conclude something on the laboratory side, I looked at the 2012 numbers. What kind of requests are we getting? Approximately 25% of our requests are TPMT testing, mainly from dermatology. Then we have like 25% on cytochrome 2D6 in psychiatry and 2C19 testing. And one of, I think, the successes, which I left out in my talk courses already addressed earlier, is, of course, the HLA-B5701 in HIV. That went very rapidly. No convincing of clinicians. As soon as we had the test available, it was requested. They're very happy with it. So it fulfills, apparently, a clinical need. And it works very well. So approximately like 25 or 20% of our test requests are now being from HLA-B5701. As you can see, there's some 2C9 and some cytochrome 1A2 and a few like cytochrome 3A4 genotyping. If I compare that in the total of the Netherlands, I did a survey there to have some idea on the pharmacogenetic testing. I think there are approximately 10 to 12 labs that do pharmacogenetic testing that I'm aware of. I got the data from 6 labs, approximately 5,000 genotyping patients genotype per year for pharmacogenetics, and it's mostly in psychiatry. There are 2 big psychiatry clinics who do genotyping before they start therapy. So if we're talking about the uptake of pharmacogenetics, I think at least in the Netherlands, we're improving there. What about the procedures? I heard something about that yesterday as well. How well should the test perform? The way we work with this is the following. As soon as a sample comes in from the patient, we split it 3 ways. One part goes in the -83 as a reference. And then the remaining is divided in 2 parts. DNA isolation is done separately. And the reason? Just to make sure that there is no sample switch down the line somewhere. Just to make sure that there's no sample switch anywhere. The second part is we're not analyzing with one platform. We use 2 different platforms to do the SNP analysis. And that's because we have seen from our experience that approximately 1% of genotypings is wrong. Platform will give approximately 1% of wrong genotypes. It's a matter of the PCR. It's the matter that you are amplifying only 1 allele when you're expecting to amplify 2 alleles. Of course, there can be a SNP under one of the PCR primers. So every technique is suffering from this. And of course, nobody is doing it in 2 ways. Nobody knows. And then again, 1%, how bad is that? It's not clear. Nobody set a standard. Can you have 10% error rate, 1% error rate, 1 in 1,000? Nobody defined that. I like to see it this way. If we're doing TPMT genotyping to detect 0.3% of the population as a poor metabolizer, then apparently 1% error rate is too high. And it depends, of course, on the gene. For antidepressants, might be less dangerous than for the TPMT. Further, we participate in proficiency scheme. We have results in approximately 4 days. We can do it in 24 hours if necessary, and we give a specific dosing advice. Some observations of this 2-year platform approach, just to give you some idea, that all platforms suffer from this. We rerun in the beginning like 300 TACMAN samples for cytochrome 3A5 by PCR-FLP, and we saw that there was 1% discrepancies. 3 patients who were clearly like homozygous were heterozygous if we redid them with PCR-FLP. The AmpliChip missed 2 star 6 alleles in patients due to SNP under one of the primers. 2 PCR-FLP samples were caught wrongly due to weak bands on the gel, and we detected that through comparing with TACMAN results. Our Luminex system failed to identify 2 cases in hundreds to give the right genotype. And if you think that sequencing is the right technique, the golden standard, we even had that direct sequencing was wrong in 1 case, in which the PCR-FLP said it was a heterozygous individual, and the sequencing said it was a homozygous wild type. There was a SNP just close to the sequencing primer, and because of that, one of the alleles was not amplified. So also sequencing can be wrong. And one of the nicest things, the TPMT star 3B, when I talked to Bill Evans, he said, I don't think it really exists. So I identified 6 papers, which they reported they found this TPMT star 3B, and I asked for the patient samples. In none of these cases, it was TPMT star 3B. They were all genotyping errors. So I think there's something to say on having like 2 platforms to do the genotyping. Then how do we report our results then? Well, we specify the request, we give the problem, we say what is the material, just to make sure that I know if we did the DNA isolation or not, the alleles which we test for, and then you have the result on the star allele level for 2D6, and we say it's 2 inactive alleles or 1 active, 1 inactive allele. The interpretation, poor metabolizer, and the advice, this genotype should fit with 30% of standard dose of imipramine. And after that, extra information on SNPs tested, duplicate analysis, techniques used, frequency of predicted phenotype, limitations of the test. And then it's signed by clinical chemist who's responsible for the test and hospital pharmacist who's responsible for the dosing. It's a lot of text, and a lot of the physicians say it's just too much. I just want to know, like, poor metabolizer or not, or should I increase or not? But of course, it's not that simple, because if you go from the star 4 to poor metabolizer, you lose information. But in order to be practical, I think this is a way to go. Okay, so can you go to your local pharmacist now with the genotyping results we provided to you? And the answer is, in the Netherlands, you can do that. There's this initiative from the Royal Dutch Pharmacy, KNP, and they have literature reviews with 15 experts, and I'm happy to be one of them. And we, based on the evidence from literature, we provide those recommendations based on the genotype. And the chair of that committee is Dr. Vera Denier, who's here in the audience. I think it's a very good initiative because not only it gives you an idea what to do with, for instance, the 2D6 genotype, not only for the drug for which it's requested, but for many other drugs as well. And for in all of the Netherlands, we're getting the same advice because it's nationwide. So you do not have that in one hospital, you get different interpretation from the other hospital. I think it's a big advantage. It's also available from PharmGKB now because of the collaboration. And you can see here, it's from the Dutch Pharmacogenetic Working Group guideline. If you are using imiprimin, poor metabolizer, reduce those by 70%. So with this, I hope to have shown you perhaps some new hurdles in the implementation of pharmacogenetics. I think unawareness of the test was in a lot of cases one of the items why pharmacogenetics was not used. Competition with common practice, test accessibility, costs, turnaround time should be quick. If you have to wait for 6 weeks for the result, clinicians do not want it. It needs to be like tomorrow or preferably today, but okay, they can wait for 1 week, I found out. Translation of genotype to phenotype needs to be available. Difference in screening prior to therapy or diagnostic testing, I think there's a difference there as well. And convincing clinicians, like I said, uptaking guidelines, the catch-22 principle. And to finalize, we're going to hear some talks about accompanying diagnostics as well. I think if you look at those new developments, then perhaps several of these items are not that important anymore. But then we're still like with test accessibility, cost, and turnaround time, which would be the remaining questions. Thank you very much for your attention.
Thank you, Dr. van Schaik, for an interesting presentation. One question allowed, please.
Thanks, Ron, for a very interesting and very on the bench aspect of pharmacogenomics. I think it was beautiful. And one issue which is very important is to characterize the phenotype. And that's another problem that must be emphasized maybe. If you consider clopidogrel and 2C19, in the big meta-analysis, they only registered cardiovascular events as such, and then with the big studies. And then they don't see very much influence. But if you define the genotype to myocardial infection, or infarction or stent thrombosis, all studies are below 1/200 in size. And if you do meta-analysis on that particular phenotype, you find a very high odds ratio. So we have to be very careful reading the papers more than we are doing to define exactly when we do reviews or guidelines that we dissect what actually they are doing, measuring DNA, measuring which alleles, and how do they define their phenotype.
Yeah, I totally agree. Yes, thank you.